Friends, so today we are going to understand the concept of calcaneum fracture fixation operative case. Okay, so what our plan for today is? First, we are going to understand the salient concept of calcaneum fracture fixation operative case, which is important to understand before you operate any case of calcaneum fracture fixation. Those concepts are very important. Following which we will see an operative case of a 30 years old gentleman who had a history of fall from height, following which he sustained right sided calcaneum fracture. So without further ado, let us quickly discuss about the salient concept, following which we can directly go to OT to discuss the operative case. Okay, so what is the operative procedure of calcaneum fracture fixation? Before going to the OT of before operating a case of calcaneum fracture fixation, you should be very clear with the basic anatomy of calcaneum bone. You need to take the calcaneum bone in your hand. And understand the beautiful anatomy of the calcaneum bone. Only after which you should be going to an OT of calcaneum fracture fixation, following which, after understanding the basic anatomy, the operative procedure becomes a cakewalk. The operative procedure and the radiological evaluation and the significant factors which need to be restored for anatomical reduction will become a cakewalk after understanding the basic beautiful anatomy of the calcaneum bone. Okay, so without further ado, let us discuss first the bony landmarks. Okay, so this is the lateral surface. This is what we are seeing from the lateral surface. Okay, so the most important part is the posterior facet. It is the articular border. It articulates with the talus. So one of the most important is restoration of the talocalcaneum articulation. Okay, so the posterior facet is the most important because it articulates with the talus. Okay, the other important landmarks are this is the anterior process. Okay, the second is the this is the sinus tarsi. This part is the sinus tarsi, because above it there is talus and below it there is this groove. So this space becomes the sinus tarsi. Okay, this space becomes the sinus tarsi. Moving forward, this part you need to be very clear. This part is the sustentacular tali, the sustentacular facet. It is there over the medial aspect. Let me repeat this 3 to 4 times. This part is over the medial aspect, which is the sustentacular facet. Okay, and this groove is over the lateral aspect. Why am I repeating it multiple times? Because this is the part which confuses you in the intraoperative CM, and you feel that this is the angle, but this is not the angle. This is what you see is the sustentacular facet, which is over the medial aspect, and this is the angle which we need to worry about. Okay, so this is the second part which is important. So we discussed the posterior facet, anterior process, sustentacular facet, sinus tarsi. Okay, clearly this articulates with the cuboid. So this is the facet for cuboid, and this is the lateral peroneal tubercle. This is the part which helps us in entering the calcaneum, which is the calcaneum tuberosity. Okay, so these are the what we discussed as the important aspects of the bony landmarks. So posterior facet is most important, articulates with the talus. Then the anterior process, sustentaculum tali or sustentacular facet, which the FHL groove passes, through which the FHL muscle passes, and it has a groove for the FHL. Now the calcaneum tuberosity is the place, as you all know, where the Achilles tendon insertion is there. Okay, then sinus tarsi we discussed, middle facet. This is the middle facet. Okay, this is the middle facet, and lateral peroneal tubercle. It has the groove for the peroneus longus and brevis muscle. Am I making sense? I hope this basic anatomy is clear. This is most important. Before going to OT of calcaneum fracture, you need to understand this basic anatomy. You need to understand this basic anatomy. Okay, so that you can imagine the reduction intraoperatively. Okay. Now, operative key. This slide is the most important slide. This slide, there are 5 targets. There are, before we go to the OT, this is the slide you need to mug up. This is the slide you need to keep in mind before going the OT. Intraoperatively, you have to perform the task which helps you achieve these 5 goals, these 5 targets to achieve anatomical reduction. Calcaneum fracture fixation, once you understand the concept and anatomy, it becomes very interesting. But if you are not clear, it becomes a very difficult thing intraoperatively, and you might give terrible result to the patient. Okay, forward, the 5 targets which we need to achieve is, first, most important, talocalcaneal posterior facet should be, we should achieve the parallel articulation which we discussed over here. So here is the talus, here is the talus. So you need to achieve this congruency, this congruity you need to achieve. Articular congruity is important, which is disturbed in calcaneum fracture. Okay, which is disturbed in calcaneal fracture, which is the most important to be achieved. Number 1. Second, the Bohler's angle. So the Bohler's angle is the angle between 2 lines. First line is from joining the anterior process and posterior facet, and the second line is joining posterior facet and calcaneal tuberosity. Okay, so I will show. It might look very complicated, but it is very simple. What is Bohler's angle? It is the angle. So the angle from the anterior process to, first line is anterior process, this is the anterior process, this is the top of the posterior facet, this is the anterior process, this is the top of the posterior facet. So first line is this. Okay, and second line is joining top of the posterior facet to the superior tuberosity of the calcaneal. Okay, so this angle, this is, or this side, both these angles. Okay, this is the Bohler's angle. Normally it is between 20 to 40 degrees, which is important to be achieved intraoperatively. Okay, so whenever there is calcaneal fracture, we will discuss about the various cause. There is decreased Bohler's angle. Okay, so am I making sense? Bohler's angle is from anterior process to top of the posterior facet, and the second line is joining it up to the calcaneal tuberosity. Okay, I'll repeat it multiple times. Why it is important? It is very important to intraoperatively see whether we have achieved the reduction. Okay, that is important. So that is the Bohler's angle. Normally it is 20 to 40 degree. Throughout the OT, when we go to OT, we will discuss about this angle. Don't worry, you will understand what I am saying. Okay, the second angle which is crucial, which is the crucial angle of Gissens. Okay, it is the angle between downward and upward slope of the superior surface, that is the posterior facet of the calcaneum. Okay, this is very important. This is very, very important to be restored. The Gissens angle is between the two slopes, of the posterior facet, which is the with normal value, it is 120 to 145 degree. Okay, 120 to 145 degree. So both these angles are important in the dead lateral view intraoperatively. Okay, which is most important in the dead lateral view intraoperatively. First is this angle. The angle, first line is this, second line is this. Okay, this should be 20 to 40 degree. The second is this. Okay, I'll repeat it. I'll show it again. Okay, this is the Bohler's angle. Number one line is this, second line is this. Okay, joining these 2 points and these 2 points, this should be 20 to 40 degree. And the second is the angle of Gissens, which is this slope angle. Simple, you remember this slope angle is Gissens, which should be, as you can imagine, it should be 120 to 145 degree. And this, the Bohler's angle, should be 20 to 40 degree. Okay, now intraoperatively what you need to keep in mind is, this is the Gissens angle. What is this part? You tell me what is this part? We discussed in the anatomy. It is the sustentacular facet. So intraoperatively sometimes we make a mistake that we consider this as the angle. No, this is not the angle. This is not the angle. Now you see that you have to make sure you are looking at this margin. Okay, am I making sense? Am I making sense? So these two angles are important. Bohler's angle, which is normally 20 to 40 degree, and Gissens angle, which is the crucial angle of Gissen. It is normal value is 120 to 145 degree. Okay. So whenever these angles are disturbed, there is, you are suspecting a intra-articular fracture or a joint depression. So we'll repeat. Whenever there is Bohler's angle, decrease in the Bohler's angle, we are more likely dealing with a severe posterior facet depression. And whenever the Gissens angle is disturbed, we are dealing with a displaced intra-articular calcaneum fracture. So what you need to remember is restoration of the talocalcaneal articulation, anatomical articulation. Bohler's angle should be restored and Gissens angle should be restored. Now, these are the factors you see. In lateral radiograph. First three you see in lateral radiograph. The second two you see in the Broaden's view or the axial view of the calcaneum. So in the axial or Broaden's view, you need to check the correction of the heel widening. You need to check the correction of the heel widening. And the second thing, you need to check the correction of hindfoot varus. So whenever there is excessive varus at the calcaneum due to fracture, both these factors need to be corrected intraoperatively while checking the axial view. Okay, so the five factors: talocalcaneal articulation, Bohler's angle, Gissens angle, heel widening, and varus. These are the factors you need to understand. Okay, so now fasten your seat belts. We are going to the OT to discuss a 30 years old gentleman who had a history of fall from height, following which he sustained a calcaneum fracture over his right heel. Okay, so these are the preoperative radiographs. So you need to take the lateral view and you need to take the calcaneal axial view. Okay. So in calcaneal fracture, we need to check about the primary fracture line and you need to check about the secondary fracture line. Okay, so whenever this is the primary fracture, whenever there is this is the usual place where the primary fracture line is, and the secondary fracture line either it goes like this or it goes like this. So whenever it goes like this, it is classified as tongue type fracture. And whenever the secondary fracture line goes like this, it is joint depression type of fracture. Okay, so these are the preoperative x-rays in which you can see the disturbed Bohler's angle, Gissens angle, calcaneal height. Okay, in the axial view you can see heel widening. Okay, so all these factors, all five factors are disturbed in the preoperative x-rays. Okay, we'll delineate more, okay, in the preoperative C-arm. So we have shifted to OT. Okay, so we are seeing the C-arm of the patient, of the 30 years old gentleman who is posted for calcaneum fracture fixation. Okay, so in this case we'll analyze the Bohler's angle. Okay, it is less than 5 degrees. We calculated in the PC, in the system, it is less than 5 degrees. Okay, needs to be restored. Okay. Along with that, we calculated the Gissens angle. This is sustentacular tali. We need to check about this margin. Okay, so it is also increased. So we calculated the exact values. In our preoperative planning. So Bohler's angle, we checked in the X-ray and we checked in the C-arm. Okay, so the Bohler's angle was less than 5 degrees. When we saw the preoperative X-rays along with the C-arm, and the Gissens angle was approximately 160 degrees. So both are deranged. Normal Bohler's angle is 20 to 40 degree. However, over here it was less than 5, and in there the Gissens angle is normal is 120 to 145 degree. Over here it was increased by 160 degree. Additionally, the fracture line is extending like this. The secondary fracture line is going like this. So which type of fracture it is? It is a joint depression type of fracture. Okay, so now we will understand how we operated the case. So there are multiple modalities, multiple factors are important. The general conditions, comorbid condition, diabetic patient, the skin condition, the type of fracture, how old it is, all these Based on all these factors, we decide the plan of our management, the modality of our management. It could be open lateral extensile approach, plating, it could be K wires, it could be CC screws, it could be shank spin, depending upon the surgeon. There are multiple factors, but today we'll discuss about my operative case, which I operated with CC screw, 6.5 mm CC screws. Okay. So before this is the, we'll understand the views are very important to one for in a calcaneal operative case. Okay, so this is the dead lateral view, okay, which is the most important view, which is the, okay, and the second view is the broadens view, in which what do you do, you dorsiflex the ankle, and the CM is 45 degrees cephalad. The CM is at the angle of 45 degree. Okay, that is how you understand the clear axial view to check for heel widening or heel varus. Okay, so both these views are very important. Usually we keep the patient in lateral position so that it becomes easy for us to operate for it, so that it becomes easy. We have applied now. Okay, so this is the preoperative CM, in which you can see the collapse of Bohler's angle, in which you can see the collapse of Bohler's angle, in which you can see the collapse of Gissens angle. Okay, which you can see the collapse of Gissens angle, and you can see the fracture line, the secondary fracture line, which is causing the joint depression type of fracture. Okay, so we need to restore first we need to restore the Bohler's angle. To 20 to 40 degrees. Second we need to restore the Gissens angle to 120 to 140 degree. Okay, so the maneuver which we use for the reduction is the classical maneuver of Essex Lopresti. Essex Lopresti Manoeuvre is the best maneuver in which you can reduce and anatomically reduce the angle of Gissens and Bohler's angle. Okay. So how do we do the Essex Lopresti Manoeuvre? So I'll show in the further video how do we do the Essex Lopresti Manoeuvre. We insert the ST pin. Just lateral to the calcaneal tuberosity. Just laterally over the calcaneal tuberosity, we insert the ST pin. ST pin is advanced, and you advance it up to just below the posterior facet. You don't go further, because this is how we are going to reduce. I'll show in the maneuver in clinical intraoperative video which I took. Okay, so you don't advance it more than the posterior facet. Okay, so the ST pin has been advanced. Now we'll shift to OT to check how we reduced with the Essex Lopresti Manoeuvre. Okay, flex to 90 to 110 degrees. Between 90 to 110 degrees, knee is flexed, the knee is lifted off the ground, and then we perform the Essex Lopresti Manoeuvre. So we have passed the ST pin at the calcaneal tuberosity. Okay, now we are going to undergo the Essex Lopresti Manoeuvre. So what we'll do, we'll push the ST pin inferiorly. Along with that, we'll do plantar flexion maneuver. So now in this case the Bohler and Gissens angle have been disturbed. Okay, so now in the live shoot you will see how it is getting restored. Okay, so now we are going to distract, and gradually you will see the Gissens and Bohler angle. We'll try to reduce it. Okay, if sometimes it doesn't get reduced, you can do the milking maneuver. To restore the Bohler's and Gissens angle. Calcaneal tuberosity. Okay, now we want to correct the Bohler's angle, Gissens angle, and the articulo-talocalcaneal margin. Okay, so we will plantar flex the foot, entry aspect of the foot with one hand, and we will step in like this for the reduction maneuver. This is the reduction maneuver. Okay, and restoration of the calcaneum height along with both the angles which I described. Okay, so as you can see, there is continuous plantar flexion which is going on, and the ST pin, and we are pushing the ST pin inferiorly to get the compression and get the calcaneal height, to restore the calcaneal angles, now you can see the Bohler's angle is getting restored. Gradually the Bohler's angle is getting restored up to 20 to 40 degrees. Okay, and the Gissens angle is also gradually becoming 120 to 140 degree. Before it was 160 degrees and Bohler's angle was less than 5 degrees. Okay, so this it is what you have to maintain. This is what you have to maintain throughout the OT till you fix it with the CC screw or K wire or whatever modality you have chosen. Okay, moving forward. Okay, so we are maintaining the plantar flexion and the push or at the calcaneal by the Essex Lopresti Manoeuvre. Okay, so this is we are getting the perfect angle. This is the Gissens angle which we have got perfectly anatomical, and this is the Bohler's angle. This is the Bohler's angle which we have got up to 20 to 40 degrees, and 120 to 145 degrees Gissens angle we have achieved. Okay, the word of caution over here, is this part. What is this? This is sustentacular tali. This is not the posterior facet. This is the sustentacular tali. Okay, so to calculate the Gissens angle, this is the margin. This is the margin which you need to understand. Okay, heel widening. As you can see, there is heel widening. So multiple maneuvers used. You can use some blunt end. You can use a hammer or you can use a clamp. Usually these clamps, patellar clamps or these type of clamps also work wonders in reducing the heel widening. Or you can also use something blunt end. Okay, at the same time you can manually also with your fist try to reduce the heel widening. Okay, so this is we are at. Here's another case in which we are correcting the heel widening using the clamps. As you can see in further CMs, satisfactory correction of the heel widening is achieved. You can also use some blunt end of the some instrument. The angle appears to be anatomically reduced. The calcaneal height appears to be anatomically reduced. The fracture line, secondary fracture line is still persistent. Okay, so one assistant holds this in the Essex Lopresti plantar flexion manner. Okay, and now we are inserting a guide wire at the calcaneal tuberosity for the CC screw to pass. So we have inserted the guide wire. That depends the way you are approaching a case. That depends on multiple factors. The fracture line. Okay, so the first CC screw, my plan is to hold it like this. Okay, here the secondary fracture line is there. So second CC screw, my plan is to hold it perpendicular to the fracture line. This we will discuss in subsequent CMs. Okay, so that is what our plan is. Sometimes if after putting one CC screw like this, this is either you go from medial aspect or you go from lateral aspect. If it is not stable, if you inserted the screw first through medial aspect, you can insert the second screw parallel to it through the lateral aspect. That depends on the intraoperative stability and surgeon's choice. Okay, so moving forward, this is the guide wire. Now we have drilled it. Okay, and after drilling it, we have inserted the 6.5 mm CC screw. Okay, the threaded or non-threaded, half threaded, fully threaded, depends on the surgeon's choice. I usually prefer fully threaded. Some for compression use partially threaded. That depends on the surgeon's choice. Okay. Here's another case in which we want to get some relative compression. So we are using partially threaded, half threaded CC screw. As you can see, we got satisfactory compression. Okay. At the same time, as I said, it is important to keep checking the heel widening. At the same time, the alignment of the varus, which is important to be seen at every moment after putting the screw. Okay, so we have passed this first screw. Okay, so this is the first CC screw, which is holding the primary fracture line. This is holding the primary fracture line. Okay, now we are attempting. Now what our plan is? Okay, we want to attempt to reduce this secondary fracture line. Okay, that depends on surgeon. You can also at the same moment pass a second CC screw over the, if you pass from medial aspect, you can pass over the lateral aspect if you feel that you haven't achieved significant compression at the primary fracture line. In this case, I could achieve significant compression at the primary fracture line. So now I am addressing the secondary fracture line. So this is the second guide wire. So my plan is, this is the fracture line. So my plan is to go absolutely perpendicular to the fracture line so that I can get best compression. Okay, so this is where I am entering my second guide wire. My plan is to go like this, perpendicular to the fracture line. Okay, so I have gone perpendicular to the fracture line. Okay, and I have drilled it, and then I have put the screw to cause the compression at the fracture side. Okay, then I've drilled it, and then this is the guide wire, and I have started putting the second CC screw to cause compression over here to reduce the secondary fracture line. And I have got satisfactory, I am getting gradually I am getting satisfactory compression. This is where you have to be very careful while you drill, while you put the screw, because this articulation is important. You should not damage this part anyhow. Okay, now going further, as we are tightening the screw, we are getting the compression, as you can see. Okay, gradually we are getting the compression, and subsequently we are getting satisfactory compression. As you can see, we cannot see the secondary fracture line now. Okay, we cannot see the secondary fracture line now. At the same time, you need to keep looking at the angles. You should not be playing with the angles, which is important. Okay, at every moment you should be, if needed, you should perform the Essex Lopresti maneuver, or one person should be one assistant should keep holding the foot in the Essex Lopresti maneuver, okay, as required. Okay, so now as you can see, we have got satisfactory compression at the primary fracture line, we have got satisfactory compression at the secondary fracture line. Along with that, the angles appears to be anatomically reduced. Okay, so as you can see, these are the final CMs at the end, in which we are seeing the primary fracture line being compressed by this CC screw and the secondary fracture line being compressed by the second CC screw. Along with that, the angles are anatomical. This is sustentacular tali, this is the posterior facet, this is the talocalcaneal articulation, this is the calcaneal tuberosity. Okay, this is calcaneocuboid articulation. Okay, so satisfactory calcaneal height is achieved, satisfactory angle of Bohler and Gissens have been achieved, and satisfactory varus is there, and heel widening we have been able to correct satisfactorily. Okay, so we calculated it. So preoperatively it was less than 5. Okay, in 1 cm it was around 2 to 3 degrees, in X-ray it was less than 5. So on an average, the preoperative Bohler's angle was 5 degrees, the angle of Gissens was around 160 degrees. Okay, and normal is 20 to 40 degree, and Gissens angle is 120 to 145 degree, and post-operatively we are able to achieve the Bohler's angle between 25 to 30 degrees and Gissens angle between 125 to 130 degrees. This you can calculate in the CM, or you can calculate in the post-operative X-rays. And visually also you need to keep checking about the angles while you attempt the fixation with a screw or a K-wire or the plate. Okay, you can see satisfactory correction of the Gissens and Bohler angle. Along with that, there is significant compression at the primary fracture line and significant compression at the secondary fracture line. Along with that, the most important aspect, the talocalcaneal articulation. This is the most important. The five factors in which I said the first one was the restoration of the talocalcaneal angle, was the restoration of the talocalcaneal articulation. This is the most important. Further on, we check the Bohler's angle and the Gissens angle, and heel widening and heel varus. So we are confirming the dynamic stability using the dynamic CM shoot intraoperatively. Okay, so this was a case of calcaneal fracture fixation in which we could get satisfactory correction of the angles and alignment. But it is important throughout the OT, at every moment you need to keep on visually analyzing all the angles. Along with that, you need to keep checking the compression. Okay, if required, if you feel that the stability of the compression of primary fracture line is not satisfactory with first CC screw, you can put a second CC screw. Our initial plan was to put one more CC screw, but intraoperatively we could get absolute stability. You can see in this dynamic shoot, and that is why we kept the fixation with 2 CC screws. Okay, here's another case where you can see beautifully the correction of Gissens angle with Essex Lopresti Manoeuvre. So as I said, calcaneum fracture, you need to understand the basic anatomy. If not, it will be a nightmare OT for you and the results will be terrible. But if you understand the basic anatomy, you understand the radiological findings and angles and the alignment, it will become a very logical understanding and lovely cakewalk to operate. Okay, So calcaneum fracture, or any day you need to take care about the wound complications, right? The patient selection, the modality absolutely depends on meticulous preoperative planning of all the inclusive factors, including the general condition of the patient. Okay, I hope this video was useful in understanding the salient concept of calcaneum fracture fixation. Along with that, what all factors you need to take care before operating the case of calcaneum fracture, and how do you operate the case of calcaneal fracture intraoperatively. I hope this was useful. This is Dr. Mihir Tejura signing off with calcaneum fracture operative case simplified for you. Stay tuned for further operative videos and tutorials of practicals and theoretical concepts in my channel Bones Orthopedic Simplified for You by Dr. Mihir. Thank you so much, guys.